as this conference winds down, do I have my slides here? Great. So the conversation is actually going to keep going here, and we would like to do that online. So go ahead and keep using that hashtag #NACannabisConvo, and make sure that you post your thoughts on how this all went, what you learned, and what your takeaways are. We want to keep all this great dialogue that we've had in the room going online as well. Oops. So we've also posted a poll on Twitter, and we'd like to get your input on sort of how often you want to interact and chat with the summit. So please vote, please reply with your ideas, and retweet that and share it with your colleagues. So it's now my pleasure to introduce this absolutely great panel that we've got here today, and it's going to be led by Susan Weiss. She's the director of the Division of Extramural Research at NIDA, and she oversees the extramural programs, research training activities, operations planning, and trans-NIH initiatives such as the Adolescent Brain Cognitive Development Study. She also serves as a senior science advisor to the NIDA director and is scientific liaison to other federal agencies. And in her 16 years at NIDA, Dr. Weiss previously served as chief of the Science Policy Branch and acting director of NIDA's Office of Science Policy and Communication. So let's give it up for Susan Weiss.
Thank you very much, and welcome everyone. It's really nice to see such a crowd here still this third morning. This is probably not the sexiest topic, so I am really pleased to see that everyone is here. We think it's obviously a very important topic, and we know that there are a lot of different types of surveillance that are necessary to inform public health, to inform public policy, and to help us determine the resources that we need for prevention and treatment and ways in which we can hopefully mitigate some of the concerns that may come up in a very rapidly changing policy environment. I think that cannabis surveillance is particularly challenging because both the speed of the changes that are happening, and as we've been hearing about the nuances of the laws and the ways in which they're implemented, which are likely to produce very different outcomes. And so it becomes very important to be tracking all of these things and to provide data. The fact that this is happening so fast also means that we needed baseline data yesterday. And while we do have federal surveys and we do have states that have been doing surveys for a number of years, we're not necessarily getting answers to all of the questions that we really need to know. We have other problems, like there are no agreed upon standards of measurement. The products are changing. People that are using cannabis products are using them for different reasons. They're using different products. People of different ages are using different products. So this is a very challenging area to do surveillance in, and all of this, as we've heard, is happening in a much larger political and economic context that also is influencing how policies are developing. So it's incredibly important that we are able to provide data that is objective and that is useful to a variety of people who are implementing different public health policies within the states. And I'm very glad that we have such a diverse group of people here today representing these interests. So with that, the way we decided to do this is that we are going to do a question and answer among the panel, and at the end, if there is some time left, we'll also take questions from the audience. But I'd like to give the panelists a second to introduce themselves, and then we will start the question.
Thanks, Susan. My name is Gillian Schauer, and I'm a senior consultant to the National Institute on Drug Abuse and the Centers for Disease Control and Prevention.
Hi, I'm Dr. Althea Grant-Lenzy. I'm a senior advisor for science for the Deputy Director for Non-Infectious Disease. I had to pause because we change our name all the time. At the Centers for Disease Control and Prevention, and there I coordinate our work around cannabis.
I'm Dilley from the state of Oregon, senior research scientist. I'm sitting up here today as a co-chair for the Council of State and Territorial Epidemiologists Marijuana Surveillance Subcommittee.
Good morning, Hanan, Abramovici, Senior Science Advisor in the Cannabis Legalization and Regulation Branch at Health Canada.
Okay, thank you. So I think one of the things you realize is that we do have we have people that are coming into this with very different perspectives, so I think this will be an interesting discussion. So why don't we just start out talking about why surveillance for cannabis is important in this current legal climate,
Thanks, Susan.
changing climate.
Yeah, so from a Canadian perspective, surveillance and monitoring is really important for a number of different reasons. One of the reasons is that in the summer of 2016, when we started this journey of legalization and regulation of cannabis in Canada, the Canadian federal government struck a task force whose purpose it was to advise the government on a framework for legalizing and regulating cannabis. And the task force submitted a report on how to do this. And in that report, they had over 80 recommendations. And one of the recommendations, or a couple of the recommendations, were that Canada have a robust surveillance and monitoring system in place, and two, that it conduct surveillance and monitoring in order to determine the impact of legalization and regulation on a number of different outcomes. And that leads me to the second point, which is in our legislation, the Cannabis Act. That legislation has essentially two key priorities: to protect public health and public safety. And there are a number of sub-objectives to that act. Having surveillance and monitoring will really help to understand what the impacts of legalization are on public health and public safety. We also, in our act, have a mandate to report back to Parliament after a certain number of years upon which cannabis is legalized. So we need that data to be able to report back to Parliament and to say, has this initiative been successful? Has it not been successful? If so, in either case, what went well, what went wrong?
Gillian?
Thanks. So from a state perspective, the folks working in public health in state and county health departments are using data all the time for planning programs and designing campaigns and understanding where the public health burden is and what the disparities are. So if you're in a state or a county where legalization is being contemplated or implemented, and if you haven't gotten the email yet that says, where's our state's data, or where's our data, then you should check your spam filter, because that email is definitely coming. And in the absence of any kind of state or local-based surveillance data, we're fortunate to have very strong national data, so we can definitely use that to set the national context and to get a sense of where we are at with regard to the nation. But I want to make a pitch for as much state-specific surveillance as possible for a couple of different reasons. One is your state survey data are usually available a little bit faster, so they'll give you a better sense of the most current status of your state or locality. Second is the state data sets are usually designed to be more representative of your state or your local entity. So the national surveys will pick up folks in different states, but they're usually not designed specific to your state to be representative and give enough information about specific populations. And then third, your state systems can be more flexible, so you can adapt them and include the highest priority questions for your own stakeholders.
Thank you. So given the challenges of developing these different surveillance tools and some of the compromises that have to be made with respect to costs and burden, what do you think are the most important domains and indicators that we need, and what are and how do we prioritize those?
From the federal context, as has been mentioned, in the United States, we have a number of surveys that do ask questions about cannabis use. I think there are some limitations to those, however. Increasingly, many of those questions are a bit out of date. Updating those questions is quite a process. Unlike Canada, we do not have a federal mandate or federal funding for cannabis surveillance in the U.S. So as Julia said, I think that makes state-based surveillance increasingly important because of that. However, we've learned that states have developed their surveillance organically, with each state really figuring out on their own what are the right indicators, how do we ask these questions, and that's the prime reason that I helped facilitate a federal-state coalition to really think about what should the key cannabis indicators be that we are recommending that states use. And we came up with 9 for adults: past 30-day use, or number of days used in the past 30, mode or method of use, so smoked, vaped, etc., amount used, type of product used or product characteristics, notably CBD, THC products, reason for use, is it medical, non-medical, or both, cannabis use disorder, secondhand marijuana smoke exposure, household exposure to any marijuana, and impaired driving. We have a separate list of measures for specific populations that you can hear more about this afternoon, including youth, medical users, and pregnant women. And we have secondary measures that we've offered to states as well. Now, I will say one of the challenging things in prioritizing these is how they've been operationalized. And I'll talk in a little bit about some of the limitations, but in short, we really don't have good, well-tested, well-developed, validated questions for a lot of these. For example, if we just look at CBD and THC, we know that most users actually can't report whether they're using a high CBD or high THC product, and they often misreport the THC content. So there are a lot of opportunities, not just to say these are the right indicators, but to look at how we operationalize those.
And I think also, depending upon how things are changing in the states and the policies that are there, if they are better labeled, then some of these things will also be changing and will make some of these surveillance efforts a lot more accurate. Hanan, do you want to say something?
Yeah, from a Canadian perspective, you know, when we first started again down this journey, there were three ministers that were tasked with legalizing cannabis in Canada: the Department of Health, Health Canada, which is where I work, the Department of Justice, the Department of Public Safety, and we kind of sat around and tried to but find out or map out the different indicators that we thought would be important. And the starting point was what are we already collecting? What are we already collecting through all of our surveys, through all of our databases? What are the things that we're tracking? And that was the starting point. Realizing, of course, that we need to expand what indicators we were interested in looking at based on the evolving legislation, the regulations, the objectives of the legislation, which are to protect public health and safety, to protect youth, to dampen the illicit market, to ensure a safe supply chain for cannabis, and to raise awareness and to educate Canadians on the health risks of cannabis. So we expanded that initial list of indicators to try to cover these areas. And then we also consulted a lot with scientific experts in surveillance and research to validate these indicators, to help prioritize them. And so we did that in a couple of different workshops sponsored by our Canadian Institutes of Health Research to try to prioritize indicators, and also to determine which indicators are feasible to do, which ones are not. Obviously, like everybody else, we have restrictions around what kind of data we can collect, funding to collect that data. So all of those considerations factor into how we prioritize our indicators.
And I think one of the other important issues, and one of the reasons why it's good to have somebody from Canada on this panel, is that to the extent possible, we need to be harmonizing measures. So we need to be collecting similar data and be able to sort of put that in the context of the policies that are being implemented. So I think it's very important that we keep talking to each other. What do you think are some of the best data surveillance systems that are available now, and what are some of those limitations associated with them?
So this is a question that's, I guess, near and dear to my heart because about, 5 years ago when I embarked on working on cannabis, I was given the following directions. We need to improve surveillance. You have no data, no staff, no money, and no mandate. You have no office and no division to work in. And I want you to, focus on what CDC can do to improve surveillance. So given that mandate, I think that we started with what I think was probably the best place for us to start with federal level surveillance. One of the things that we usually do is leverage existing surveillance systems. So we, like other agencies, like NIDA and SAMHSA and others, leveraged our existing behavioral health population-based surveillance system. So NIDA has Monitoring the Future, SAMHSA has the National Survey of Drug Use and Health, and CDC has a whole list, including the behavioral risk factor surveillance, the youth behavioral risk factor surveillance, and others. Why I think that was the right decision, I'm not saying I did the right thing, but why I think that was the right decision is because there were several advantages to that. One, all of those systems, because cannabis use does not happen in isolation. We're talking about people with other comorbidities, other behavioral risk factors. All of those systems collect information about those other risk factors. So that allows researchers and public health folks to analyze other things that may be going on with the individual and other outcomes that they may have. The second is cost. It is very expensive to start a standalone surveillance system. It is tons easier to add 1 or 2 questions to an existing surveillance system. So the marginal cost of adding surveillance to a whole bunch of systems is a lot less. The third is you already have infrastructure. So I was given that mandate and not a lot of time. And so if you had to build a standalone surveillance system that had to collect information, it would take years to stand it up. If you have existing infrastructure that you can use, you can think of a question, test it, and have it out the same year, and have data within a year. So I think those were the things that were advantageous. I'm also going to say from the federal side, there are some limitations to what we do as an approach. One of the limitations is because these are existing huge surveillance systems that already have tons of questions, it takes an act of God to argue that your question is so important it should be included, and so therefore you can only ask usually 1 or 2 questions in that surveillance system, so that really limits what you can ask. And secondly, these systems have been going on for decades, and they're trying to monitor trends over time. So if you have a better way to word one of their existing questions, again, it takes an act of Congress to change the wording to be flexible. And cannabis is an emerging and flexible area where we actually do need to change questions every year. So I just want to throw that out as one of the limitations of what we do at the national level.
So just a comment, because NIDA does Monitoring the Future, which is a survey of 8th, 10th, and 12th graders. And we have a little bit more flexibility there because that's actually done as a grant mechanism, and so we don't have to go through all of the same processes to try and change a question. And we have been able to add questions in a much more timely, a much more time-sensitive fashion. I think the problem with Monitoring the Future is that there is so much data being collected that's not being analyzed, and so I would just sort of make a plea to people to actually try to look into getting a hold of some of those data. These data are to be made available to other researchers, and I think there is really a treasure trove of information in there that actually we don't do the analysis on, and that would be helpful for us in better understanding a number of different areas, but particularly around marijuana.
So from the state perspective, I'll just share that our CSTE Marijuana Surveillance Subcommittee has been bringing together folks working at the state level who are doing surveillance, and we're trying to develop sort of a practice-based evidence. So based on the experience folks are having, what is working, what is meaningful and useful, and what's less meaningful and useful. And I just want to second what these guys have already said, that the existing surveillance systems within states are definitely the place to start as the best place to get information. So the behavioral risk factor surveillance system, school-based youth behavior surveys, and the pregnancy risk assessment monitoring system. So within states, it doesn't take an act of God to add and change questions, but it does take sort of a minor miracle. And so when you're in the position of wanting to add some questions, I really encourage you to turn to the list that Gillian's been leading the development of. So there's a short list of candidate questions to include, but you're also going to need some stakeholder support, because in many states there's a sort of a process for adding, and you have to go and make the case that we need cannabis surveillance questions just as much as we need flu shot questions and other kinds of questions that are also very important for public health. And even though it is very much more cost-effective to add questions onto those surveys rather than to build new ones, it's still fairly expensive, and most states are charging per question within your state, so it can be multiple thousands of dollars to add, even 2 or 3 questions onto your behavior risk factor survey.
Thank you. So could we talk a little bit more about some of the limitations to the surveys, and particularly to developing some of these newer indicators that reflect current use practices?
So I want to elaborate a little bit more on cognitive testing, and for those of you who haven't heard of that or don't know what that is, it's really cognitive qualitative interviews with participants who answer the quantitative question, and then you follow up to understand how do they interpret the concepts, how did they arrive at their answer, and what the reality is for cannabis questions is very few of them have been cognitively tested. And as we've started to do cognitive testing, we are actually learning that in many cases what we thought we were asking about is not what we were asking about. So, driving, for example, I think every state has been asking a different question for impaired driving. We started to cognitively test those and very quickly understood people have too many variables here and they can't provide a valid answer. So I think getting funding, not just to field the surveys, which is, as you heard, challenging federally and at the state level, but funding to develop indicators and test indicators is a huge limitation. And we're working in concert with Canada to figure out how can we pool resources and do some of this important work. I would also point to unifying the wording across questions, and that's been a struggle as we land on a good question. Like right now we've got a pretty good question for mode and method of use. We have a number of states who say, well gosh, we are beholden to our trends, and so it's really going to be hard for us to make a change to this. I think the dynamic marketplace is also challenging. We are already delayed in what we're asking about, and by the time we get questions tested and fielded and data in, the products are already different. So living in that space is a challenge. And then finally, survey modes. I think our surveys, for the most part in states and federally in the US, are phone-based, household-based, or paper and pencil. And we would really be in a better position if we could use pictures, use web-based approaches, both to reach the main populations using cannabis and to be asking questions with the right skip patterns.
Gillian, did you want to say something?
Yeah, thank you. So in some of the limitations to cannabis surveillance work, I wanted to talk about 4 things where I add a limitation but also maybe a solution or an idea. So not having resources early on is a key limitation. The story Althea told is exactly the experience that we've had, many of us at the state level or local level. And most of those places you don't have anything to work with as you get started. So using those existing lists that Gillian has identified and working collaboratively with other states and consulting with one another about what's worked best, definitely the way to go for that. Another limitation is the coordination is hard within states. Unlike other topics, this has been a funny one in that people who have key data sources that you need access to all seem to sit in different agencies, different buildings, and it's very difficult to get everyone's attention and bring everyone together. So a solution that has worked for us in Oregon is to have a high-level leader who's a real champion for surveillance and can make that a priority for folks and getting folks together and spending time on it. We've also mentioned not having enough space on surveys to get the information that you need or get enough information from specific types of populations. In some of the states, we've set up parallel data collection systems to sort of enhance or complement the established surveillance system. So for example, in Washington State, they designed a new surveillance system for young adult behaviors. In Oregon, we're using an online panel survey to complement our BRFIS and ask more of the detailed questions about cannabis use that we can't fit onto our BRFIS. And then the last challenge, which has already come up, is what is most important to measure. And I feel like this is really tough, particularly with regard to the health outcomes associated with cannabis use, because the evidence base is mixed right now. For some of us in surveillance, we're sort of monitoring everything and starting to wait and see what happens. So, yeah, that's just kind of what we have to do for now. And I think continuing to share among our peers about what we're seeing and what we think it means is just critically important.
Did you want to make?
Yeah, just really quickly, one of the advantages of being at the end is that everybody said everything that needed to be said already. Just a couple of perspectives from Canada really quickly. Some of the data, some of the surveillance data lies at the provincial level, and so if we want, at the federal level, if we want access to some of that data, we need to know what kind of data provinces and territories are collecting. B, get them on board to share their data, have to put together data sharing agreements. That can take a lot of time. It can take a lot of time to come to an agreement about what kind of data will be shared, how, when, and so on. And also, different provinces and territories might be doing different, measuring different things. So it's harmonizing and standardizing the data across all the different provinces, getting them to report similar things so that we can all speak the same language. And I can come back to that a little bit later in another question as an example of that. And the one last challenge really quickly, Indigenous data. So we're trying to get more and more data on the impacts of cannabis, comparative use, behaviors, all that amongst our Indigenous population, and that's a challenge for us right now.
Yeah, I think the other issue, which Althea has already alluded to, is that I think most of us are interested not just in cannabis use and the health impacts, but also we recognize that this is part of a pattern of other sorts of either substance use behaviors, or there's a lot of concerns about the linkage between cannabis and mental health. And so again, being able to somehow cross-talk some of these surveys so that we can try and get some sense of how these things relate to each other, because it's important that we can see the big picture and that cannabis is not just happening in isolation. I think that, so what do you think are some of the most important emerging areas where we need to be collecting more data, given all the changes that are happening?
So we've been having a lot of discussions recently around some vulnerable populations that we're really concerned about at CDC. I mentioned before, we all have monitoring feature, YBS, NIDA, who has great information on youth, and we're concerned about youth, and we know that policymakers are watching youth. But one of the populations that we don't have very good data on at all is pregnant women. And we know that that's a priority population for a lot of the states. Now, if you looked at the recent NIDA data, it suggests that the temporal trend is that the rate of marijuana use among pregnant women may be doubling. That would be very concerning if it turns out that that is true. Unfortunately, it's hard for us to really know if it's true because there's so many limitations right now to how we collect data on pregnant women. Julia mentioned that we have PRAMS, which is called the Pregnancy Risk Assessment Monitoring System in some states. I want to come to our session in the afternoon, you'll learn that it's not in most states, so we have a lot of limitations to the way we collect data on pregnant women. And it's actually a much more challenging area. I worked in reproductive health for many, many years, and I find that it's a much more challenging area because although we're collecting information from the pregnant women, we're very, very concerned about the outcomes of the infant. So we need good clinical data on the infant at the same time that we need data from the pregnant women. So as Susan was talking about, crosstalk between data systems is critical for that indicator. The second is that Gillian mentioned that we've done cognitive testing. And our cognitive testing on pregnant women suggests that they don't tell us what they're doing. And so getting a lot of false negatives in our results is very concerning. I just want to say someone did a presentation, the rescue agency, and they presented like rates as high as 20% in California, 25% in California. And I have no idea if that's right, but if it is right, we need to be getting on this. So I really just want to also say that we also need to do certain things when we collect data on pregnant women that are special because there are some legal implications for them reporting that they're using illegal substance, and so there are all these things we need to do to collect that information. So that's definitely an area that we at CDC are prioritizing. And I just want to put a plug in before I wrap up on the second area that we've just started to prioritize, and I've seen talks on it here, is what are physicians doing? Like, we woke up one day and like the whole country had medical. Not the whole, I know there's a few states who don't, and we did a recent survey, and it was really shocking to see what the physicians feel are the indications, how many are doing recommendations, and what they're saying to patients. So that's another area where we think we need a lot more data, not just MDs, but all healthcare providers, including nurse practitioners, nurses, etc.
Yeah, and that's also critical because we want physician education, and there's a big gap in that right now as well, and I think in many ways that gap is being filled by industry, and we want to make sure that the information that's being provided really is an accurate representation of the data. And you heard from Dr. Grant yesterday that there's still quite a lot that we don't know, and that many of the states have indications for which there's absolutely no data whatsoever. Not to mention just the confusion sometimes between THC and CBD, or at least the not being very explicit about how they are different and what their potential uses may be. Hanan, did you want to say something about emerging areas?
Yeah, sure. I mean, some of the ones that we're interested in, I mean, obviously we're interested in pregnant breastfeeding in individuals and some of the other areas that were raised, but a few others are building on some of the work that we've been doing on the medical medical side for a number of years is looking at adverse reactions or adverse events to cannabis, both for medical purposes and for non-medical purposes. Under the medical access system, the commercialized system that we've had for about 4 or 5 years now, we've been collecting that data, but we want to do that. We're actually doing that for non-medical use, and it's actually in our regulations that regulated parties like licensed holders and licensed producers of cannabis have to report serious adverse reactions to cannabis products within a certain amount of time to Health Canada. So we're doing a lot of that monitoring, and we're building up that system to make it even more robust. Another area that we're really interested in is calls to poison control centers. So we have 5 different poison control centers in Canada. They are not built to do surveillance, they're built to do case management, and so we've been working closely with them over the last few years to build a sort of a pan-national Canadian surveillance system for poison information, getting them to surveillance work, in addition to their sort of day-to-day case management. And that's to be able to roll up all the data that they're gathering at the territorial and provincial levels at the federal level, and getting them to to harmonize their data, the way they're collecting their data, standardizing their data, so that we can report on these things. So this is a surveillance system for poison information writ large. Obviously, we have a huge interest in what's going on in cannabis, so that's been a particular effort that we've paid close attention to. A couple of other things, Indigenous, as I mentioned earlier, so we're really interested in doing surveillance amongst Indigenous populations, Indigenous communities, cannabis for medical purposes, sex and gender-based analysis, really trying to, our surveys are not really built very well to look at that, to parse out the data by sex, and gender and other variables. So it'd be interesting to really build up that functionality. And I know that some other federal departments like Statistics Canada is looking at market scanner data to really get a better sense of what are the products being sold out there, get a lot more granular data mainly for economic purposes, but some of that data could also be used to help inform health-related outcomes as well.
And I think building on what Hanan said for our context here in the U.S., working more with tribal nations and with American Indian communities is going to be really important in a lot of our state-based surveys. While those communities are included, they're not included in sufficient numbers to really understand what's happening. And tribal nations in particular in the U.S. are starting to make their own decisions as sovereign nations about what they do with cannabis, and having some data to help inform that would be very useful. So we have a tribal epi infrastructure that tribal epicenters could be utilized to help provide and bolster surveillance for those communities. I think given the legalization of hemp-derived CBD from our farm bill will make surveillance in the medical landscape even more important. And again, our population-based surveys usually do not have the space and don't have sufficient and appropriate questions to really understand how are medical patients using these products. So thinking about whether we can partner with health systems, whether we can leverage EHR data, whether we can do surveys of panels of patients, I think will be very helpful in terms of gathering those important data. Hanan mentioned market data, and for those who've worked in tobacco control or even alcohol, market scanner data have been extremely helpful in driving policy and understanding how new products are being used and adopted in marketplaces. To date, the data that we have, at least in the US, in most states from the marketplace is really not well cleaned, very hard to utilize, not aggregated from state to state. So I think there's a huge opportunity to look at the data we're getting from retail stores or that regulators are getting and think about how we can continue to improve that. And then finally, young adults. If you've attended any presentation in this conference, you've seen that they are the highest percentage of users and that their use has been increasing. While we do collect data on young adults in population-based surveys, thinking about the kind of thing that Julia mentioned, user surveys, web-based surveys where you can really reach young adults where they are, will be increasingly important.
Yeah, also, we always group the 18 to 25-year-olds, and actually we probably need to separate that out given that it's not legal for, at least in the U.S., it's not legal for those between 18 and 21, and so we may need to also try and get a little bit more granular on those sorts of analyses. So one of the problems that comes up, and I think that's confusing when we're trying to give messages to the public, is that different surveys will give us different results. And I think that that's something that we have to be very clear about explaining and trying to understand. And I guess for me, the one that has been concerning for a while has to do with the rates of cannabis use disorder, which the National Survey on Drug Use and Health has shown to be relatively flat over the last number of years, which is kind of counter to what we expect given the rising potency and given the fact that we know that people that are using it more often. But then you have another large epidemiological survey called the NISARC survey, and that survey shows that there are actually increasing rates, and I think there's been a doubling of the rate of cannabis use disorder. There have been changes made in that survey, and it's not conducted on a yearly basis, but we're still struggling to sort of understand how you can get such different data from two large epidemiological surveys that are both very well conducted and that have a lot of very interesting information in them. So I think that's another issue around surveillance, that if we want to gain public trust, we need to be able to understand why are we getting different messages, why are we getting different data out of these different surveys. Althea, did you want to comment?
Yeah, and I just wanted to put a plug in for the fact that sometimes we're getting different results for very legitimate methodological reasons, but policymakers don't necessarily understand methodological reasons, so you may have to explain it to your policymakers. The one that comes up for us all the time is the difference in youth, because youth is a priority population. They'll say, well, why does monitoring the future and YRBS have higher rates than NIDA, for instance? And it's just because, one, they're administered differently, and how people respond to maybe the same question in different settings is different. So YRBS and Monitor Future are school-based surveys, and youth may be more likely to admit use in a school than they are in the house where their parents live. And so NIDA is a household survey, so you may get different results because of that. Secondly, they're actually different populations, slightly, but importantly. So if you're in a school-based setting, that means that person's going to school, right? And they're not absent that day. So that's going to be biased towards kids who are attending school, whereas a NIDA may actually capture kids who might be at high risk or dropouts. And so there may be slightly differences, and so I think it's important to emphasize when you're looking at data, not just look at the numbers, youth 12 to 17, blah, 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 but also understand who that data really represents.
Yeah, I think that is crucial. And I think the one thing that we have been sort of pretty lucky on, at least between those three surveys, is that the patterns have generally been very similar. So as they've been increasing in one group, they have done the same, although the absolute numbers are not the same. But I think that having similar patterns is at least reassuring that we're tapping into the right information. But it is, I think, as you said, it's very important that we understand the sample and that we can convey that information so that people can understand why they're seeing some of these differences.
And I think Althea brings up a good point as well, which is that oftentimes the data from these surveys are not used or interpreted correctly. And so we need to think as a community about how we make sure that people are drawing the right inferences from the data that we are collecting in the way that we're collecting it. So we're talking about big population-based surveys, which for the most part shouldn't be used to make causal assertions. They should be used to make associations and sort of shine a spotlight on areas that warrant further research, further longitudinal data collection. So thinking about how to sort of keep that in check in your states and communities is important.
So I think, one of the main reasons that we're so interested in surveillance is that we want to inform policy. And so I guess this is really our last question to the group, and that's to ask, how do you think that information that we've gotten from these different surveillance and monitoring systems has influenced policy? What are the challenges in it, and what do you hope to see moving forward?
Yeah, so again, from a Canadian perspective, right now it's a little too early to determine what the impacts of legalization and regulation of cannabis in Canada, what the impacts have been. But certainly, as I mentioned, right, it's kind of coming full circle in a sense, right at the outset, that surveillance and monitoring is going to be really important for determining whether cannabis legalization was a success or a failure in Canada, and to drive changes, if they're needed, in the legislation or in the regulations. So the quality of the data, the kind of data that we gather, the way we interpret the data, how we report on that data is going to be really, really important in determining what the outcomes will be and whether we'll need to make any policy changes or any adjustments. And we were very cognizant of that from the beginning, right? In the task force report, just coming back full circle, task force was very, very cognizant of the fact that adjustments will be needed. The task force, consulted with many Canadians, consulted with a lot of Americans, and built on previous. You guys kind of went before us, and so we learned lessons from you guys about the importance of surveillance and monitoring, building that baseline data, which we did to the best that we could before legalization, and so taking that data and trying to make sense of it to adjust if any adjustments are required.
So I was talking with one of our legal folks in the state of Oregon who had worked a lot on writing the rulemaking in Oregon around cannabis, and I was asking him, how do you feel like the relationship is going between policy and surveillance? Because ideally we want that surveillance data to really plug in and inform the ongoing improvement of policy. And he said two things to me that have just really stuck in my head. One is he said, in the beginning we've been more principle-driven than research-driven in our policy development. And then second, he said, I think it's going to be a long time before we can sit back and say, okay, we think we got it right now. And I feel like it's the same thing on the surveillance side. Right now we're sort of more principle-driven and led by the models from alcohol and tobacco than we are by evidence, but we're building that evidence base, and I think I can see the light at the end of the tunnel where we can sit back and say, I think we got it right. In terms of how policy has been informed by surveillance so far, what I've seen more often to date is that anecdotal evidence emerges of problems, then policy responses start to happen, and then as the surveillance data come in, we see a sort of justification for those anecdotal problems. So, for example, repackaging of edibles and labeling of edibles in Colorado and Washington State for pediatric folks, those changes were sort of initiated by concerns about pediatric poisoning or overconsumption concerns, and then later in the surveillance data we can see like, oh yeah, that really was more than just a couple of anecdotes. And so last, I just want to make another plug for a statement that was made before, which is that in terms of making surveillance data useful for informing policy, another strong reason to invest in that surveillance capacity within your state or your local entity is that if you do not get your surveillance data and interpret it and apply it to public health and safety, somebody else will do it for you, and you may not agree with how they've interpreted it and applied it. So again, just another reason why it's so important for you to become the expert about your surveillance data.
And I just wanted to also plug in, sometimes we are looking for major things to happen. I think when major things don't happen, it also informs policy. I think one of the reasons we're having these conversations about additional states legalizing, et cetera, is because we didn't see dramatic trend shifts in some of the vulnerable populations like youth that we were looking at. And I think people felt more comfortable making that decision looking at the surveillance system, not seeing dramatic increases.
I think the other piece that warrants some discussion as part of the session is the policy tracking piece. So for us to really be able to have our population-based surveys inform policy, we need to have good databases of those policies themselves. And we have a couple in the US that are federally funded, M.E.S, which is funded by NIAAA, and PDAPS, which is funded by NIDA. They're fantastic for research purposes. They're not as current as policymakers might like them to be, but we really need to look more at how we overlay detailed policy databases with the kind of population-based surveillance data that we're getting to understand what's happening. And people are trying to do that, but they're trying to do that in what I would say is often a crude way of just, is this state medical or non-medical? And there is so much more detail that needs to be considered. The other thing that I would suggest is timeline is particularly important. So a lot of states are seeking to draw policy conclusions by looking at any baseline they have, a year or two before adult use legalization. And in most states that have legalized for adult reasons or adult use, they've legalized medically far before that. And so some of the changes to use patterns and behaviors may have happened with their legalization of medical use, and they may need to be doing analyses that go much further back. And then finally, and Susan will have the last word on this and can elaborate much further, but I think there's a huge opportunity for a symbiotic relationship between research and surveillance, and I think surveillance should be informing where research goes and vice versa, for us to understand where we need to be having new questions and developing better indicators. We also will need to look to the research.
Thanks, I completely agree. Also, I just wanted to make one other point about why we also need different types of surveillance systems, because as you said, some of these larger surveys may not be showing very dramatic changes, but then if you're looking in emergency room data, or if you're looking at poison control data, you're starting to see things that may be important and that may be signals that we need to be watching. Even the problem of hyperemesis or hyperemesis is one that people really were never talking about before, and it's only now, because this is coming up in emergency rooms and it's clearly associated with cannabis use, that we're starting to look at that. And again, this generates research questions about how these things happen and how you can deal with them. And at the same time, research should also be informing the types of questions that need to be in these different surveillance systems. I mean, one of the things we've talked about, I'm coming back to, is cannabis use disorders, which is something that's very difficult to do in a population survey, and is critical in a lot of different research surveys, and is well characterized in many of them, but it's very difficult to come up with a single question that's going to give you the answer that you need, and you can see that even on these very large surveys, we're not necessarily getting the same answer, so we need to do a better job with that, and we need, again, surveillance, as you said, surveillance to inform research, and other kinds of research, and research to inform surveillance, and they really do have to be, it does have to be a symbiotic relationship. I think we also, we're happy that we have had Canadian colleagues that we've been able to talk to as this process is unfolding, because I think we want to leverage what's going on in different international settings, and it's not just Canada, it's also Uruguay, and it's also Mexico, and it's also other places which have different, both different cultures, but also different ways of implementing their cannabis policies. And I think we need to be working together to learn and to continue to identify what are the most important variables that we need to be watching if we want to mitigate any harms, and we want to prevent sort of going back either to a system that disproportionately affects non-white people, or we want to prevent all of the things that we've done terribly wrong in the past, and not create another system that's going to have just a whole different set of problems that is also going to disproportionately affect some more than others. And we heard a lot about that on day one. So that's really all that I wanted to say. Thank you very much. I think this has been really helpful to hear the different perspectives, and we can take a few questions from the audience if we have some. And Rosalie seems to have one. Surprise.
How about a round of applause for us right there? We're going to get the mic set up for some questions. Folks who want to ask questions, line up over here. We'll have that mic set up for you in just a second, so everyone can hear what you want to know.
Okay, this is going to come as such a complete shock to most of you, but I'm really concerned about our lack of good surveillance of the markets per se. NIDA had a series of questions on marijuana markets that were not ideal, but the only thing available that got dropped in 2014, and despite tremendous pressure, I still don't know for sure that they're coming back. Maybe you do, Susan? But
It's hard to hear, so.
the marijuana purchase question on NIDA.
Yeah.
So for my concern in most of the systems, we do need to have better measures of use and intoxication. Those are really important in products. But this is not a commodity being sold like tobacco or alcohol or other products. And the state systems, as most of you guys know, 1 unit could be a pound of the substance or 1 dose of the substance. So the even the seed to sale data is not useful for understanding the market. I believe it's really important in these systems at the state level where we're surveying kids as well as adults, that we include some questions about their engagement in the market and the prices paid, because that's going to be the only thing that we have to gauge things until this market is much more mature. And so I strongly encourage that. And there's a second point. Also, I didn't hear in many of the surveillance systems the criminally justice involved populations. That's been one of our key sources for understanding markets and some of the hardcore users for the illicit drugs because of it being such a marginalized population. I still think that that's a very important population to capture here. Cannabis is not legal for youth. they will show up in the criminal justice system, and we can learn a lot by capturing information there.
Yeah, I can start from sort of the broad-based state perspective about how purchase price, and some states are able to ask those questions. I think the big challenges are main sources of information are these big population-based surveys where states are routinely being told, okay, you get 4 questions. And that just, while it's critically important, sadly has not risen to the level of being one of the top 4 for states, but it's really important, and along with that, getting a better gauge on amount used, we know is important, and that is really hard to do on a population-based survey, and that's why some of these web-based approaches, where you could use pictures and you could have associated price, and I mean, we can all sort of visualize what the grid would look like. It would be like, what are the modes? How much of each mode? You know, what's the price you're paying for mode? Where are you getting it? That would be amazing to have, but right now the state infrastructure for population-based outreach is not set up for that type of thing.
What about the rotating modules, though? MTF does it, I know nationally. They have sub-modules that they ask 1/6 of their surveyed in any given year, and then the CDC allows each state to add in a particular module. Something that allows us to go into depth for a subset seems like a way to let it compete with the other important public
Yeah,
health.
are you talking about like BRFSS modules and NHIS modules? So they're still going to be beholden to the survey approach, which is, you know, paper and pencil. It's not online. And it costs a lot of money, as Julia said, for states to field our BRFSS module. I mean, if you want to hear about a nightmare in funding, we can talk more about that. CDC has to pay to add questions, then states have to pay to use the module. And while we know that most states want to use the module, I think we only had 12 in 2016 that could figure out where to actually get funding. And the challenge for states in that is that if they're not a legal adult use state yet, they probably don't have a public health program that has a funding line item for cannabis that is working on cannabis. So we have to help them get quite creative about, can you go to your behavioral health? Can you work with this non-public health agency who might be able to fund because they're interested in the data? But I'm sure you have more perspective, Julia.
I'll just say that I think the market data are incredibly important, both price and access and product type. And most of the regulatory folks I've talked to, they analyze their own data quite a bit, but not from a public health lens. And I feel like we can get there. We've started to play with that a little bit, trying to find a few key indicators that we can all agree are quality, and also give us some information about the availability and accessibility of product. But I completely agree that it's a challenge too.
And I just want to reiterate Gillian's point. The cost has been a huge barrier, so much bigger than I ever thought it would be. We added 3 questions to the RFSS, which sounds like very few from a cost point of view, but as she said, most states could not take it up. And I talked one-on-one with the folks whose job it is to do that, and they were like, we just don't have money, we have to get money from this agency or that agency just to do those 3 questions, so it's really challenging.
And I would encourage research in the area. I mean, that is something where we are trying to encourage more policy research. So that doesn't get at the sort of overall, getting at sort of what's going on in all of the states. But I think that we're certainly interested in trying to get ways of developing the right measures and figuring out how to take advantage of it. And so, as you know, come in.
If I could just add a little anecdote from Canada. So we've invested lots of time and effort and money into gathering that market data, looking at, we have a Canadian cannabis survey that we've had in the field for 2 years, gathering baseline data, and now we're going to keep doing the survey over time to really understand the knowledge, attitudes, and behaviors, including purchase patterns, price paid, what kind of products are people using. There's a lot of questions in that survey, both for medical use and for non-medical use, really trying to understand how Canadians who are using cannabis, how do they interact with cannabis in a really granular fashion. There's also a lot of work being done by Statistics Canada, another federal department, really trying to get at the economic side, trying to understand, again, purchase patterns, market data. So we're gathering, we're collecting a lot of data, market scanner data, as I mentioned earlier, so there's a lot of work being done on that front.
We only have a few minutes left.
Okay, next question.
I'm a clinician, not an epidemiologist, but I want to say that this is a brilliant panel, and it gives me great comfort in the face of the pressure from the advertisers in marketing. But I do have a question about another population that's expanding use, which are elders and people with chronic pain. And I'm wondering whether there's any hope of, in Haynes or any place, beginning to capture people who are really trying to use this in a medical way that would allow us to get some population sense, not just of people with disorders, but with people who are doing medical use.
Yeah, so that's been really challenging to say specifically that people are using it medically. So we do have data systems that capture elderly or older populations. BRFSS does. We do, and Haynes has marijuana questions in Haynes, obviously, and we updated them this year to be more relevant. And they also obviously have specimens and a lot of clinical data. But to figure out whether people are actually using it clinically, we found to be much more challenging because most consumers that we've surveyed so far are using it recreationally and clinically, even when they're using it medically.
In our population-based surveys, fewer than 10% report just using for medical reasons. So that's one of the reasons to call out the medical population as warranting potentially a separate survey, maybe working with a health system to reach them. In the population-based surveys, they're often using for both medical and non-medical reasons, and we don't have sufficient space for questions to say, well, just think of your medical use and answer these. Just think of your non-medical use and answer these.
But you had mentioned yesterday that there was a survey, there's a registry in Minnesota. Yes.
I just want to give a plug. I don't know if Tom Aronson is here, but he gave a really great presentation a day ago about what they're collecting in Minnesota for their medical registry. I think it's a treasure trove. Minnesota has fairly restrictive medical policy, and therefore they are doing annual surveys on their population who's using it medically. They're collecting information at point of sale. They only have 2 producers, so they know all the products that the people are using, and they have 2 reports on their website characterizing the population. So Minnesota, I just want to give you a plug that you may be a wealth of data. They also are following opioid use and other things in this population, and have the capability of abstracting medical records from everyone with a card. So throw that.
Hi,
One more question.
thanks. So I'm Jenny Pearson. I'm an assistant professor at the University of Reno. And, UNR.
Okay.
And I'm a tobacco regulatory scientist. And I am struck by how similar this conversation is to conversations we have at our scientific meetings, and just take cannabis out and insert e-cigarettes. And so I really, it's not a question, it's just, I implore everyone in this room that we need to talk across, drug interest areas, because I have actually learned a lot from people who have been working on cannabis surveillance and applied those ideas to e-cigarettes. I think we could do the same thing on the other way, especially when it comes to questions about purchasing patterns, how much you paid, where you got the product from. A lot of these questions could be asked in very similar ways, and in fact, I think several of you have published on the idea that cannabis may be augmenting or displacing nicotine or tobacco use, right? So we really need to ask these questions similarly, so that we, in analyses, we can actually look and see if there is some exchange back and forth between these drugs. And I don't know if Rachel Granite is in the audience right now, but she's at NCI. She is co-leading an effort where we're actually working on ends or e-cigarette questions right now, trying to put together recommendations. So it seems like we should all talk.
Yeah, so a couple of things. I also work with the Office on Smoking and Health at CDC, and CDC has a cross-division, cross-office work group. So we do talk internally at CDC, and federally we have a surveillance work group where we have engaged, for example, the NCI, the top NCI person on tobacco. So we are having those conversations, and I think we're all well aware of the fact that we shouldn't be molecule specific, especially when we're talking about a device, like a vaporizing device, that is not just being used for nicotine, is not just being used for cannabis, is being used for synthetics. So we are constantly trying to work to figure out how can we have better questions that focus on a device or focus on overlap of all substances. Those are challenging questions and will require some funding to do psychometric work and cognitive testing. But I think we're well aware of the overlap, and to the degree that we can address it, are trying to do so.
Yeah, I think it's very clear that we have a long way to go, but that this is also really crucially important as things are moving forward. So thank you all for your attention and for your questions.
How about a big round of applause for our panel?
Just to remind you, you can hear a little bit more about some of these different surveys and the data at 1:30, and that is in the Emerald Room.